Salter, who's keeping us up to speed on those restrictions.
Let's just hope we get with some of this heat comes some pop-up thunderstorms or something that gives us some rain. It's just been so long.
It'd be nice.
All right, I see it's 5 o'clock. Let's see, do we have a quorum? We have 1, 2, 3, 4, 5.
I believe we do with Dr. Verbeest and Dr. Rhodes
Yes.
are here now.
Fantastic. Well, all right. Well, if no one has an objection, I'm going to go ahead and call the June Board of Health meeting to an order. I hope everyone's had a great last couple of months. It was wonderful to be on site last time that we met, and hopefully we'll get to be on site again later this year. But hope everyone's surviving the heat. I want to first welcome a new team member, Ms. Cortez, who is taking over for the retired Donna Murphy. So Lillian, if you want to take a second to introduce yourself and welcome to your first Board of Health meeting.
Thank you. My name is Liliana Cortez, and I'm excited and nervous to be here.
No reason to be nervous. We're a very nice and patient group. Thank you very much and welcome to the team.
Thank you.
All right, so first order of business is to review the agenda and see if there are any adjustments to the agenda that was circulated. All right, with no adjustments to the agenda, we will go ahead and I think we have to approve the agenda as is, if I'm not mistaken. So if someone would make a motion to approve the agenda as is.
So moved.
I think I heard a second in there. Yep, perfect. So we can go ahead and start the roll call.
Dr. Ray,
Yes.
Dr. Jackson, Mr. Brown, Mr. Gregorio,
Yes.
Dr. McDougall,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Rhodes,
Yes.
Dr. Silberman, Commissioner Valentine, and Dr. Verbeest.
Yes.
All right, fantastic. Thank you, everyone. Next item on the agenda is a review of the previous minutes. They were circulated. I had a chance to review them and didn't see anything that needed adjusted, but is there anything within the last meeting minutes that anyone wants to have adjusted or modified? All right, hearing none, we'll accept a motion to accept the minutes as is.
I move to accept the minutes as is.
Second.
Motion is it's been motioned and so seconded. We'll go ahead and have the vote, please.
Dr. Ray,
Yes.
Dr. Jackson,
Yes.
Mr. Brown, Mr. Gregorio,
Yes.
Dr. McDougall,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Rhodes,
Yes.
Dr. Sullivan, Dr. Silberman, Commissioner Valentine, Dr. Verbeest.
Yes. And good job with my last name.
I practiced. Thank you.
All right, thank you very much. All right, next on the agenda is public comments. Are there any public comments? Don't think so.
No, sir.
Okay, fantastic. All right, next on the agenda, we will turn over to Dr. Jenkins for staff and program recognition.
Good evening to this great board. I will say Dr. Ray stole a little bit of my thunder, but I definitely wanted to give praise and welcome Liliana to this great board. Ms. Cortez has been on her second week and she keeps showing up. So I figure that she's pretty tough and wants to do a great job. But in all seriousness, she has been properly trained by Donna Murphy, who's enjoying retirement and certainly cheering her on from the sidelines. And she is definitely hit the ground running. So we certainly want to say thank you to Lily for choosing us and choosing this opportunity. And other than that, just really want to give praise to the leadership team. As you all know, we have been coming out of a very tough budget season, and they have worked together collaboratively to come up with some solutions, particularly when it came to that 2% operating cut that we had to do. But they worked together, and I couldn't be more proud to have them on my team. As I've said to this board, we've stuck together through the pandemic, and 6.5 years with the same group is something to be said, with the exception of those who've chosen to retire. But other than that, Mr. Chair, that's all I have as far as staff and program recognitions.
Thank you very much, Dr. Jenkins. Appreciate all the hard work of everyone in the department. All right, next item on the agenda we have 3 administrative reports this evening. The first one is our Q3 fiscal overview, and Ms. Gwendon is going to present that, so I will turn it over to you.
Thank you, Dr. Ray. Appreciate that. And good evening, everyone. I'm going to share my screen here. And how does that look? All good? Awesome. Thank you.
Looks great.
All right. All right. As Dr. Ray said, I'm here this evening to share with you Q3 of fiscal year 25-26. Although we are well into Q4, those Q3 books are pretty nicely tied up, minus some still outstanding revenue. So we work backwards a little bit here. First and foremost, I'd like to share with you all about where we started the year and where we are currently. So we started this fiscal year with a bottom line budget of $28,410,835. We've moved $1,301,649 into the budget this year so far, with amendments and various rollovers. So our current budget as of Q3 is $29,712,484. Our expense budget is $41 million. $41 million is a 4% increase from where we started the year. And again, that's from various budget amendments, grants we've picked up along the way, that sort of thing. We've spent $25.95 million, or 63% of our general fund expense budget as of Q3. Personnel costs total $17,775,203 in Q3. Contract spending is $6,426,096. Some specific purchases that you may be interested in from Q3 are: we have purchased $9,912 of opioid supplies. We've bought $6,434 worth of medical supplies for the dental clinic and $4,060 in medical supplies for the maternal health clinic. Lastly, $3,330 worth of pregnancy guides, which are in Spanish for our centering pregnancy groups. The department has brought in $6.7 million in revenue as of Q3, making up 58% of our revenue budget. As I remind you all, each time I present, revenue is never quite in real time. So we're behind 1 quarter on our quarterly directed payments from Medicaid, which is a large amount. Similarly, while grant revenue is expended year to date, the revenue runs about a month behind as well. So here on this slide, you can see where that Medicaid lag is that I was mentioning. Our grant revenues are totaling $3,613,220, and Medicaid is at $2,529,615. So both are steadily increasing as we like to see. And as usual, those two sources make up 92% of our overall revenue budget, which is right in line with what's typical. I think it's been 92% the entire fiscal year. Our service fees, which include patient self-pay as well as environmental health, is $454,978. And lastly, I always like to mention a few of the opioid settlement projects that we have going on. We have $968,000 budgeted for this year for our 3 projects, community linkages to care, harm reduction, and also the administration of the county's opioid activities. We have a budget increase right this quarter of $30,000, which was used for naloxone purchases. And at the end of Q3, we've spent about 54% of our budgeted expenses. So Dr. Ray, while this presentation is about Q3, I did want to also just take a moment to share one thing, and I'm going to pull up another document if this will let me. Okay, we have, this was a milestone that was just reached today. So I wanted to take the opportunity to share with the board. This is a kind of an internal spreadsheet that we use to track our grant funding. So apologies for, how remedial this looks, but we have, this is a list of all of our state grants for the current fiscal year. The state fiscal year ends at the end of May. So we're just now submitting our June report, which finishes us out for the fiscal year. So here we have all the AAs, or the numbers, the various grants, their name, what cost center they're in, how much is budgeted, and then how much we have expended and then also received the revenue back. So if we scroll down here to the bottom, you'll see that that's about a little over $4 million. And this fiscal year, we've collected 95% of those grants that were awarded to us. So this is a metric that we are absolutely thrilled with. Of course, we want it to be 100%, but within the context that Dr. Jenkins was talking about with, the tight budgets that we're under, as well as all the federal policy changes that we've been seeing. There's one on here that we didn't quite get all of the money for, but it was for refugees where, we've seen a lot of change in our refugee population, so we weren't able to draw that. So given that, this percentage is, really outstanding, and all credit is due to the leadership team, to the program managers, to the administration staff pulling these funds and spending these funds. I'll say the first year that I was here, this number was at 90%. Last year, we went to 92%, and this year 95%. So really thrilled with the direction this is going in, and I'll brag probably about that later on when I'm telling you more about Q4. But since that happened today, I just wanted to share that as well tonight. Happy to take any other questions.
Well, first, fantastic work to you and the team. Appreciate you putting that information together for us. And I don't work in the grant space, but I take it from all the people that are giving thumbs up that do that's really strong work. So fantastic.
Thank you.
I don't have any direct questions, but I'll turn it over to anyone else who has any questions for Ms. Winden. All right, hearing none. Thank you very much.
Thank you.
All right, moving along, the second item on the administrative report section is a new item, the Health Director's Dashboard. And Mr. Zeta is going to present that to us. So I will turn it over to you.
All right, thank you so much. I appreciate everyone's time and allowing me to present for you all. So give me one moment. Right, I think I'm good. Yeah. Okay.
Still loading.
Okay. Let me know. Here we go.
Oops, there it goes. Okay, now we can see it.
Great. Okay, so great. So this is the first iteration. We've gone through a couple sub iterations. I don't want to call them version ones. They've kind of been half versions. As a developer, I've kind of learned to never label something version one until you're ready to present it. So this is kind of where we're at with version one. We've had a lot of different communications with all the different managers. I've worked with my manager directly and deputy health directors to kind of fine tune this document and really get it up to speed and make it feel like it's ours and that we've really got good control over it. And after the conversation I had today with some leadership folk, it felt like we're in a really good spot and we're moving towards even greater spots. So I'll get into that a little bit later, but starting together, this health director's dashboard is centralizing our public health data for our leadership decision-making. Each year, our department manages approximately 1.5 million individual data points across our public health data sets that are held within this dashboard. I've developed this health director dashboard to bring together public health data for multiple program areas into one centralized, accessible location. Previously, when I was working on this, I had multiple different dashboards for each division, and it was becoming too tedious to manage and maintain. So centralizing it into a single dashboard so that Dr. Jenkins was able to just kind of really focus on that instead of having his dental and his environmental health and maternal health and then all the other ones. So this dashboard is designed to give leadership a clearer view of key indicators, trends, and program information that support planning, reporting, and decision-making. Why the internal data structure was totally needed was before the dashboard could be built, we first had needed the internal infrastructure to support it. This included identifying available data sources, organizing information from different programs, creating consistent processes for data updates, and building a structure that allowed the data to be compiled into a single place. This groundwork was essential to move forward from scattered data sources to a more coordinated department-wide data resource. The purpose of this dashboard is to make a public health data easier to access, understand, and use. It provides leadership with a high-level view of important health indicators and department data. It helps support data-informed decisions, track trends over time, and better understand community needs. The dashboard also helps reduce reliance on separate spreadsheets, reports, or one-time data requests, which we receive a lot of. Internally, the dashboard will support leadership meetings, program planning, reporting, and ongoing monitoring of public health priorities. Staff and leadership can use it to review trends, identify emerging concerns, compare data across topic areas, and support conversations about resource allocation and program direction. It is intended to be a practical tool for improving access to data across our entire department. Unfortunately, I'm not able to display or share the clinic data with you all because it is PII and definitely don't want to cross any layers. So this is something that has been produced already. Our Dine team is an incredible team. They've been very easy to work with. They provided me with so much detailed information. It was honestly a very awesome joy to just sit there and chat with them with the nutrition education. And they have these incredible briefs. If you have not reviewed them, I would absolutely urge you to go do that because they have done some of the best work, I think, in the entire county of displaying all of their hard work and all of their hard data. So it was actually really easy for me to build this. They've already kind of managed and dedicated a lot of their time into making this accessible for all. So envision this for the clinics. It's a very similar setup to this. So currently for this past year, the nutrition education had 8,338 total participants. Total hours and minutes spent was 986 hours, staff hours of 23 minutes. The average length of a campaign that they held within Dine was 2 months and 13 days. They conducted over 1,300 sessions and had an indirect reach of nearly 71,000, so through social media. So then we have a little pie chart here, a donut chart, which I love. I understand that some people do not, but I really do think they display data very easily and helpful. 57% of the indirect outreach was directly through social media. Another 19.5% essentially were site level assets. So they were able to really kind of engage with those people at the site level. And then they produced electronic material to that number of people. Then you have a sessions held each month that kind of helps this time over trend. And you can see during the school months, during summer months rather, school is out of session. So we actually saw a decrease in our overall value. That perforated line says 125 is the average number of sessions held each month. The map to the right kind of gives us a spatial awareness of what we're looking at. We're seeing where we had our total times at those sites and where they were, which they are schools. So you can see that the high concentration of school engagement. Policy systems and environments is another thing that we are belabored with quite consistently within public health and just kind of in the government bureaucracy as it is. The concept of PSEs and really engaging with how are you managing these policies? How are you managing the systems and the environmental aspects of these different things? Dine helped me kind of rediscover how we can communicate this. So instead of just giving you raw numbers of PSEs, we actually have data that indicates like what we initiated and led the efforts for the PSEs in fiscal year 25, which was 38.1% of the time, which is really awesome to see because now you actually get to see the engagement of where that team lives with the initiation and where they led that effort specifically. They funded 40.5% and provided guidance for those PSEs there. Their total reach across the PSEs was 59.33. And then the total money entering because of the double buck programs, we love talking about money, was $372,000. They had over 1,000 double buck customers for the previous fiscal year. And then you can see that breakdown down here, the total money entering the economy because of the double bucks. And you can kind of see that cascading effect of nearly doubling, going up $100,000 and almost another $100,000 and then almost another 100,000, a little more than that. So you can really see that engagement and that drive for the double books as well. And it kind of just gives you a really simple understanding of what's going on, where these things are going. Again, going back to our beloved donut chart, we can kind of see the change topics. What did you talk about? What did you actually engage with the people when you had these efforts that you were initiating through the PSE changes? Well, a lot of them were about changing gardens, food access and marketing, physical activity processes, food quality, physical education, professional development, and also wellness. As it continues down, you can kind of see the location of where these PSE events took place. Early care and education facilities was a large portion of them, farmers market and schools. So this data is very high level, but it does give a pretty detailed understanding. This is just a screenshot, but if you were to select on one of these, if you've ever used a Powered BI dashboard, everything filters and comes alive to whatever you select on. So if we were to select on early care and education facilities, all of that data would filter down to that. And then you kind of have the breakdown of this table that shows the additional data points for the PSEs, the behavioral, the knowledge, and the overall PSEs. Moving on, this is something that has been published as well. This is in our opioid dashboard, but again, it shows and it displays kind of the theme of what we're going after whenever we're sharing this data. So we have the opioids data. We have the opioid overdose ED visits in Durham County for 2026 year to date, which is about May 19th when this screenshot was taken. So a decrease of nearly 76% versus the same dates last year. If you can just kind of envision this little KPI right here, this is kind of how in the clinics we're displaying that data as well. It's very succinct, it's very direct, and it's showing what it is this year versus last year. So we can really get a gauge of what we're kind of engaging with, what we're seeing, the trends, and it's not a verbose amount of charts. It's very simplistic, it's very high level, and it's across the top of the dashboard because Dr. Jenkins is going to have questions that he needs to answer. He can pull this up. Anyone on the leadership team can pull this up. If you're having a one-on-one with one of your providers, you can pull this up and you can review that data for that specific provider, and it will provide you insights into the workload and all the excellent effort that they have put in throughout the fiscal year or throughout their entire career here if they've been here since the state is being captured in our Epic database. So then kind of cascading downwards, you can kind of see the overdose ED visits in Durham County for the total year of year to date for the last year, which was 198. And then you can kind of see the breakdown for the overdose ED visits by month, separated by the line chart based off of the year. 24 is blue, 25 is our Durham County green, and then our tertiary color is our Durham County dark blue. And then you can kind of see the total overdose visits by ED, and this is again publicly available data published by the state, and this is just kind of a replication of what they've presented. So yeah, what I really wanted to mention for a moment, and this is my contact information, please email me with any additional questions or any concerns or anything you'd like to see. I'd have to pass it through leadership and make sure that it's available for you all. But if possible, I would like to share and communicate with you guys about the specifics if you have any. But what I've noticed is through this conversation with the team, especially with this meeting today, had a really good, insightful information where everyone was engaged and they were engaged with what the data was showing, and they were asking follow-up questions and asking for additional widgets to be built and additional pages. And that's something that tells me that this is going in the right direction because I'm getting buy-in from leadership. I always get buy-in from leadership, but it's a little bit different this time. It's a little bit more, a little bit deeper, and it's a little bit more focused on exactly what they're looking for. And that, to me, for being here for as long as I have, has really indicates that this is a good project and there's a lot of high quality buy-in. And so, like additional pages, I always try to leave something with additional, what I'm excited to do and what we're excited to look at. Today, I got tasked with building a page for Triple P, school health. Expansion on the health ed. Our health ed team has done an excellent job, and they've looked at what other people have done, and they said, let's up our game. Let's really provide a different thing. Let's really engage in the storytelling. So they've really upped how they want to approach this. BCEP, CC4C, and the pharmacy are others. And SimHeart, as I said. So like I have a few more to do for non-clinical, but we're really in a good spot. And even environmental health, we had those conversations and kind of want to uplift that even further. So I think having it all in a single dashboard has really elevated the access for all the managers. They can see what others are doing. They can see where they're at, and they're kind of pushing each other forward as they kind of review this over and over. So it's been a really difficult project, and it's taken a long time to get to where we're at. And I think we have a lot more to go, but I'm very happy and pleased with where we're at. And yeah, that's kind of all I have. If there's any questions, I'd be happy to answer them.
That's fantastic work. Thank you very much for sharing, and love to take an even deeper dive there. Just one question. You mentioned is Power BI built. Where is this available? Is it sort of does it live within the department and can be available to members of the department upon request? Is it on a website that they can readily look at? How do team members access this information?
Correct. Okay, so you have to have an account, and you have to be approved by IS&T to be able to view this. So only public health has direct access. It's behind multiple firewalls, and their access to the data is completely stripped down. But you can view the data if you are within the department on the F5 network or within the county firewall.
Okay, fantastic. Thank you. Looks like we have a number of questions. I'm just going to go from left to right. Dr. Jenkins, your hand is up first on my left.
I defer to my board members. I'll just kind of wrap things up, Mr. Chair.
Okay, sounds great. Mr. Gregorio.
Thank you, Mr. Paulzini. Great presentation and great work. Yeah, just curious, as more of a topical question, what was your perhaps most favorite insight that you all have discovered that you didn't know before?
I love that there's been a focus on getting more patients into there's a lot, but first trimester, really engaging with that. That number has increased over 20% in one fiscal year, and you can see that. And I think that's really powerful for the people that do that work. They're able to see the hard efforts that they put forth, and they can really engage with that. They can see that plus, they can see that green label, they can really engage with that. And I think it does give a lot of it makes people feel better because it's real. It's not just something that you think you're doing. You can actually view it. And so that's been my personal favorite, seeing some of the joy that I've kind of captured from some of the people talking to as we've done this project.
Because it's real. Thank you.
Yeah.
Thank you, Mr. Gregorio. Dr. Jackson.
Hello there. Mr. Zita, thank you so much for your presentation and your work on building this dashboard. My question is a little bit more kind of bird's eye view. And I appreciate your ability to be able to kind of individualize how you're constructing the dashboard for particular areas of interest and focus for Durham County. But in general, as dashboards go for monitoring health department data, how does that compare nationally as far as what data key points should be kind of reviewed and measured?
Yeah, that's a great question. So For that, I looked all around the nation because before when I was doing like a pre-processing, trying to figure out what others are doing that we're not doing that we should be doing, I really didn't find a whole lot. What I did find though was in the lab, there was a lot of detail about turnaround time, less than 60 minutes for labs. So understanding where that breakdown was, I found a couple dashboards that kind of communicated that, but it was more of like a national level. And so a lot of the data that I was finding was really from the CDC or other organizations that are more nationalized based, and then they have a breakdown kind of by state and or county. Some of them do. So I really don't know if everyone else is hiding their data or if there's not a whole lot of other public dashboards to view, because that was something that I was curious about, because you're always inspired by someone that does something so great so you can kind of replicate or build upon. So yeah, it was really difficult to find, but it's something that I do. If you find something or you know something, I would love to review it and then we can kind of integrate wherever. The last thing I have is Dr. Jenkins and my manager and a few others on my team. They were discussing yesterday. We had a document that we had to prepare for you guys. And so it's one of those things where we're wanting to build a dashboard for you all to be able to actually engage with and review. And it will have kind of our budget book measure. So I'm sorry if you're about to say that, Dr. Jenkins. I just had it on my notes and I wanted to get it. But yeah, that's really all I had. And then my great coworker is about to present to you guys. And I know you guys will love that as well.
Dr. Ray, I'm just going to say, which JP so eloquently said, we are looking at, to address Dr. Jackson's question, we are looking at, not just looking internal, but also looking external and seeing how we can tie what we do to those parameters set forth in DECO Forward, which is the county strategic plan. In addition, we also tying it to our own DECO Public Health strategic plan. So that scorecard or that document that he referenced, it's a massive document. It's beautifully written, but I have challenged JP in trying to make it more of a pictorial to really get him to do what he is awesome at doing. I put him up next to anybody in the world. He kind of reminds me of that guy from CNN doing the politics. He is that passionate about data. But I just wanted to let this great board know that that is something that's in the works. But as JP has indicated, I know as being a FAB, which is National Public Health Accreditation site visitor, that it's all individualized, Dr. Jackson and others, to that specific county health department, whether it's in Wisconsin or Chicago or State Board of Health. So to actually be able to see it and go and kind of tinker at it is almost next to impossible because it is so specific to that particular location. So I'm just delighted to know that we have what we have. It's going to be great. What I do plan on doing is, since we do meet, kind of every other month, maybe doing it quarterly, giving you a quarterly snapshot and making it a part of that health director's report as well. So just want to give it back to you, Dr. Ray, before I said all that.
Thank you very much. Appreciate the presentation and context. We really appreciate that. Any other questions before we move on? All right. The last administrative report, Ms. Carrico is going to present the review of the 2025 Durham County Community Health Assessment Survey.
Hi, everyone. Thank you. Let me see if I can share my screen here. All right. All right. Can we see my screen okay?
Looks great.
Awesome. All right. Well, thank you so much for letting me be here to present to you all tonight. I'm very honored. My name is Savannah Carrico. I am the public health epidemiologist for the Durham County Department of Public Health in the Population Health Division. And I have a lot to go over with y'all in a very short amount of time. So I'm going to probably go with the speed of light. But my contact information is at the end. If you have any other questions for me, I'm happy to answer them. So we are going to be talking about the countywide Durham County Community Health Assessment for 2026. So just as a brief overview, the Community Health Assessment is put together by the Durham County Department of Public Health, the Partnership for a Healthy Durham, and Duke Health. And we've collaborated since 2010. And so the community health assessment is required for accreditation for our local health department, but it is also required of Duke to comply with the Affordable Care Act. And this survey is really an opportunity for us to hear directly from Durham residents and uplift their voices. And in this survey, we purposefully added questions that are both quantitative and qualitative to try to capture the voices as inclusively as we could. So we pretty much threw out what we did in the previous trial cycle out the window, and we decided to just rebuild it from scratch. So this year, the biggest change between the community health assessments was the methodology with which we collected surveys. So in previous community health assessments, we have gone door to door, and we have used something called a two-stage cluster sampling method, which is also known as a scientific method. And it basically means that everybody in the county has an equal probability of being selected to take the survey. This time in 2025, from March to June, we did not do a scientific sample. We instead did a convenience sample with which we partnered with local organizations, businesses, leadership to attend events that were being thrown throughout the county geographically, throughout entire like demographics, depending on who there were there, that kind of thing. We also hired contractors instead of volunteers, and that definitely improves survey collection. So I will say the biggest difference as well is that we had an increase of 489% in the number of surveys we collected since last time. So in 2022, we collected 205 surveys, and in 2025, we collected 1,207 surveys. So obviously, this was much more successful. The one barrier we were facing initially was that we were not going to be able to weight the data, which I mean, you will not be able to generalize the data to the Durham County population. But this year, we are able to learn about a new package in R, which is a statistical software that is designed to weight convenience sample data specifically. So we were able to implement that and weight the data, which would make it generalizable to the Durham County population, which is fantastic. Here are just a few photos of some of the events we attended. So you can see some photos here. We were in the health department lobby, just asking people that were there for appointments or just happened to be there. We attended different 5Ks throughout the community. We would go to all the libraries in Durham County. So we really tried to spread ourselves out demographically and geographically as well. So what I mean with weighting is, so basically it controls for over and under representation in a sample population. So for example, in our survey, the survey participants were 66% women, and that is not the same as the 50-50 split between the general population of Durham County. So what we were able to do when we're weighting it is the underrepresented group, such as men in this example, would hold a greater influence over the overrepresented group, which is the women in this case. And so that allows us to correct for bias in the sampling and selection process as well. Here's another visual of how we were weighting the data. So John Paul, who just presented, actually built an incredible Power BI dashboard for us that was able to take in survey data in real time to track the demographics of the people we were reaching. And that would inform us on where we should go next, where we should focus, that kind of thing. And you can see from this graph, we actually did a great job of contacting Hispanic and Latinos and Black or African Americans. Because we contacted about the same as there is in the general population of Durham County. What was interesting, which is kind of unusual, the amount of white and non-Hispanics that we interviewed was less than the general population. So they were underrepresented, which is pretty unusual for a survey such as this. We typically see, more white people, especially white educated women. So I think this is a testament to our survey method and the demographic tracking mechanism that we use for this survey. I just want to point out that there are differences once you weight by the data. And that's why it's so important to weight by the data. So here are the top 5 issues affecting quality of life according to survey participants. So when it's unweighted, you can see lack of affordable housing, cost of food, homelessness, alcohol or drug addiction, and discrimination. However, when we weight by income, we notice that 4 and 5 are gentrification and unemployment, which are much more income-driven priorities. So what's the story? What is the takeaway of what we did with this community health assessment? So Durham is thriving and is rich in resources, has good infrastructure, and a diverse community. However, under the surface, there are populations not doing as well in Durham, mainly based on income. These populations face barriers to systems such as housing, healthcare, food, mental health, and much, much more. So we really noticed when we were analyzing this data that income completely shifts your idea of what a community is. All right, so moving into the meat and potatoes of the survey. So the first section we asked about was access to healthcare and health insurance. So we did ask if anyone in the past 12 months had a lapse in health insurance or coverage, and almost 20% or 1 in 5 survey participants said they did. And so that was pretty eye-opening. The biggest barrier that people found to getting healthcare was actually the cost, including deductibles and copays. However, the inability to make an appointment because the wait was too long was actually noted in each income bracket. So that was something that was across the board, something that people had struggled with. And then we also discovered that people had the most difficulty getting care from their primary care provider, but when they needed to seek medical attention, they would go to their primary care provider. And 46% of participants that reported never going to the doctor made less than $25,000 a year. So again, we're seeing that discrepancy with income. Moving on to health and housing, there were several barriers preventing people from securing housing in Durham County in the past 3 years. Overwhelmingly, it was lack of finances. And over 80% of individuals that experienced a difficulty securing housing made less than $50,000 a year annually. And so that was very eye-opening. And that really tells a story, too, of that income really drives the difference between Durham County. Or I'm sorry, it drives the difference between ability to find housing. So we also asked a qualitative question about how housing impacts your health. I'm not going to read these quotes because I know the presentation is available online. But essentially, people were saying that their home is everything to them. The fact that they own their home provides them with physical and mental health well-being. And they don't stress about having a roof over their head. But at the same time, people mentioned that there were major repairs that their house needed. They were concerned about it being insured because of the repairs that were needed. And it was just a constant back of mind thought that was in their head, especially when storms hit. And we had another person state that it was very hard to find affordable housing that is mold-free. So you do see both sides of the coin when we do talk to people in the community. When we asked about community safety and well-being and what would make people feel safer in their community, it really differed by income, as you can see by this chart. For example, for those that made less than $25,000 a year, their top priority was more safety around school. But for those that made between $75,000 and $99,000 per year, their priority was stronger non-law enforcement crisis response. So again, still seeing that income difference. Moving on to mental health, we had 60% of participants that said they experienced stress, made less than $75,000 per household per year. And then when we looked at feelings of depression or anxiety in the past 12 months, the majority was made up of $50,000 a year or less in annual household income. So we're still seeing that drive there. Continuing with mental health, I know I mentioned this previously, but the top 5 things, or excuse me, I'm sorry. This is regarding the things that make people happy, what promotes their mental health. So talking with friends or family, taking care of themselves, like sleeping 8 hours and eating well, being outside and exercising, and being creative or artistic were the top 5 things that promoted mental health. But when we take a look at the top 5 charges or causes of stress, we see that work, finances, and personal relationships are the top 3. That has actually not changed since the previous stress cycle. So these continue to be the top 3 primary causes of stress. Moving on to physical activity, nutrition, or food access, or PANFA. 3 out of 4 survey participants reported exercising regularly, which is fantastic. The most common forms of exercise are walking, lifting weights, and gardening. And the biggest barriers to exercising regularly include having no time to exercise, being too tired to exercise, or the survey participant has an injury or disability that prevents them from exercising. I wanted to show this slide on food insecurity because I think it's very eye-opening. So we asked the question, did you ever worry your food would run out before you got money to buy more? Those that answered sometimes to that question, the vast majority made up those that made less than $75,000 a year, with barely any people being acknowledged with higher income brackets within that category. When we move on to people that often worried their food would run out before they had money to buy more, over half of them made less than $25,000 a year. So again, we're seeing this crucial difference. When looking at community improvement, the top 5 issues affecting quality of life I went over in a previous slide. So again, that lack of affordable housing, cost of food, homelessness, addiction, and discrimination. When we ask what the top 5 diseases or conditions are most important to the survey participant, we see mental health overwhelmingly was mentioned, followed by cancer, addiction, heart disease, and diabetes. When looking at emergency preparedness, we see a vast, interesting data point where not even 20% of the survey participants felt they had the necessary resources to shelter in place for 72 hours during a widespread emergency. But the most common emergency preparedness step that was taken was signing up for emergency alerts, such as Alert Durham. But we did notice that the 2 biggest items that people did not have to prepare for an emergency were water and food. So that's something we definitely want to be addressing in the future. 8% of survey participants said they had not prepped at all for an emergency, and those making under $75,000 a year annually reported being more prepared for emergencies than those with an annual household income above that. And lastly, we asked a question, this was new this year, about the opioid crisis in Durham County. So we asked people to rank the services and resources needed to combat the opioid crisis from 1 to 5, with 1 being the most important. Number 1 being stronger teamwork between schools, police, health workers, and community groups. Number 2 being more places where people can get help to recover from addiction. Number 3 being providing job opportunities to help people get back on their feet, followed by tools to keep people safe like Narcan. And finally, better education programs for kids and families to help them understand the dangers of opioids and how to avoid them. So I will leave you with this, and I'm sorry if I've gone over time. To the left is a word cloud. We asked 1 question that was, how would you describe Durham in 1 word? And overwhelmingly, they are positive. You know, people obviously diverse, progressive, good, beautiful, growing, great, home, welcoming. These are all such amazing things that make Durham County a great place to live. And so I think it's very important that we highlight that. And in conclusion, so we talked to 1,207 people, but we identified issues at the institutional and systemic level. And we did notice that income drives much of the story. And we also noticed that addressing household incomes in the communities is essential to promoting the health and well-being of all Durhamites so they can thrive. And that is all I have for you at this time.
Thank you very much, Ms. Kirk. I really appreciate the presentation, really thorough, and appreciate the level of detail you went into. Just 1 quick question, and it's more just a generalization about the weighted methodology that you switched to. I'm assuming that that is, and you may have said this and I missed it. This is sort of the standard for these type of surveys across the country that moving to, is this a pretty standardized methodology that most organizations our size go to?
So it's very new. It actually
Okay.
came out of Poland, and a lot of the instructional videos are in Polish.
Oh.
So that was an interesting barrier I had to overcome when analyzing. So I first heard of this methodology from the North Carolina Institute of Public Health because they had been working closely with programmers that were able to do this type of analysis. And so they sent over kind of a Excel spreadsheet of how to calculate it, and then they had the software survey. So I compared the both to make sure they both matched the numbers. But it's a very new and unique way of analyzing convenience samples. I actually just spoke at the North Carolina Associated of Public Health Data Summit on weighting the data using a convenience sample because it's just so new. But we are able to successfully apply it to this data, which is fantastic because I looked at other health assessments in North Carolina, and we're the only one that was able to weight their data using a convenience sample.
Interesting. Wonderful. Thank you very much. Dr. Jackson, I see your hands up.
Yes, thank you, Ms. Carrico, for that exciting presentation. I wanted to ask a question about the sampling method as well. Do we know who we were missing with this sampling method versus door-to-door? Either being folks in the far reaches of the county or perhaps those of advanced age. Who do we miss?
Right. Thank you so much for that question, because that is definitely something we discussed throughout the entire process. So I would say the gaps we're missing in this survey would be younger people between 18 and 25. We ended up actually getting a pretty good and robust sample from older adults. But I will also say we did not hear from many men. And that's something we've run into in previous years, that it's just trickier to get men to take the survey. So that was a gap, definitely. And I would say that even having an underrepresentation of white non-Hispanic people was also something of a gap that we experienced as well. But I will say when we're going door to door, you're pretty much whoever answers and takes the survey is who takes the survey. But you can weight it easily because everyone has an equal chance of being selected. With the convenience sample, you're not having that probability, but we can still weight it, so it's fine. But with the convenience sample, and what we were able to do with John Paul Zitta's dashboard was track the demographics in real time and kind of focus our attention towards events that would maybe suit a certain demographic, that would maybe be in a geographical area that is underrepresented. For example, we went to the North Durham Farmers Market. We went to the North Library. So we really tried to do a broad sweep of the entire county to incorporate people that are typically underrepresented with these types of surveys.
Thank you. I'm glad to hear. Thank you.
Fantastic. Any more questions? All right, hearing none. Thank you very much, Ms. Carrico. Really appreciate it.
Yeah, thank you. Happy to be here.
All right, next item on the agenda is our public health vacancy report. Dr. Jenkins.
Thank you so much, Mr. Chair. And some not so good news. We were in the single digits for quite some time, but we have gone back into double digits. And I think it's just the season. With one retirement and one promotion and 4 resignations. I think we'll focus more on the four resignations, which, some folks just kind of went on to greener pastures and some were welcome resignations. I'll leave it like that. But with that being said, we're at 10.5% as far as our vacancy rate. We look forward to the challenge of getting it back down into single digits, but never really upset when there's a retirement and or promotion, because that's the business that we're in. That's all I have for the vacancy report, Mr. Chair.
Thank you very much. Any questions for Dr. Jenkins? All right, next item on the agenda is the NOV report. Mr. Salter.
Yes, sir. Very quickly tonight, we added 5 new NOVs in April, 2 in May, but we were able to remove a total of 9 during that same period. So that's positive. One quick thing I would like to point out, you may have noticed on the compliant list, I believe it's line 37. The address is 131 Infinity Road. You'll notice that there is no compliance date noted there. But in the note, you'll see that that property has been vacant for more than 2 years. There is no sewage discharging at this time, so there is no public health nuisance or concern there. There is an approval to have that property connected. The owner just has not connected it to municipal sewer yet. But we did add a note in the LDO. We put a condition on that property that it has to be connected before a CO can be issued for the property. So that should prevent someone from going in there, start using the fixtures again and causing a problem. Plus, if we need to, we can always go back and reissue an NOV there, but just want to make sure that there was no questions about why we removed that one and why there's no compliance date.
Very helpful information. Thank you very much, Mr. Salter. Any questions? All right. Thank you very much, Mr. Salter. Last is the health director's report. Dr. Jenkins.
For the sake of time, I know the agenda is pretty tight. I will just highlight 3 items that the board has been previously sent this information. The first, of course, has to do with Dine. In late March, Dine was in the news for their work around food security. I do believe it was Nutrition Program Manager Kelly Warnock who was interviewed by the National Association of City County Health Officials, which is a pretty big deal. It's a national podcast, and they discuss how our Dine team is addressing food insecurity and with local families. It definitely got a lot of attention. I had a former colleague who was the health director in Burke County in the foothills. He's now in Spokane, Washington. And just today, I received a nice little note with the article attached, pretty much just thanking us and saying, hey, Durham is doing big things. Keep up the good work. So just want to really lift up the Dine team to continue to do marvelous work. And a little bit more about Dine in a few minutes. Of course, we had the Women's Health and Wellness Conference that was held at Hillside High School, that was sponsored by the National Institute of Environmental Health Sciences. It was canceled back in 2025. This is always a huge event. The dental team submitted this, but make no mistake about it, yours truly provided the welcome along with Mayor Pro Tem Javier Caballera. The dental team was doing screenings. Our CD team was out there. It's always a big event, very impactful for the community. But we wanted the Board of Health to know that was something that we participated in. And the last but not least was a program that the Dine team again is participating in. And it's all about partnerships in this work that we do in public health. McManning United Methodist Church, Durham Public Schools, and an organization called Towards Zero Waste implemented a pilot food recovery program at Hillendale Elementary School. An acronym that they use for the pilot is called SHARE, which stands for Stop Hunger and Restore Earth. It's a food recovery program. And for the most part, it collects non-perishable, unopened, leftover cafeteria food items from students doing breakfast and lunch services. And instead of those foods going to waste in landfills, the leftover food is stored centrally in a located share label table, cart, or refrigerator. And students that are in need, that are hungry, can easily access this food throughout the week. My goodness, if this is not public health, if this is not helping to stave off food insecurity, I don't know what is. But I'm a big proponent of this pilot. I'm hopeful that we can get this spread throughout Durham Public Schools and beyond, because again, there should be no student, no kid, no food, no one in Durham should be hungry. They should. Mr. Chair, that's all I have.
wholeheartedly agree, and thank you for highlighting that, Dr. Jenkins. I think that's a fantastic pilot program they have going, and look forward to seeing that spread as well. And please let us know how we can support that. All right. Next on the agenda, looks like we do not have any committee reports nor old business to review. So going on to new business, it looks like there is a budget amendment that we need to review and approve. Dr. Jenkins, I'll turn it over to you.
Absolutely. Again, budget amendment. This great board is requested to approve budget ordinance amendment to recognize $30,000 from the American Academy of Pediatric Dentistry to the Department of Public Health's Dental Division for the Operation Blue Ridge Initiative. Since we already are in the business of providing services that prevent disease, promote health, and protect the environment, the Operation Blue Ridge Initiative will help us to expand access to care for patients with special needs, including physical, developmental, and/or cognitive conditions. We look forward to receiving your approval.
Fantastic. Do we have a motion to approve the amendment?
I move.
Second.
We have a motion and a seconded. We are ready for the vote on the amendment, please.
Dr. Ray,
Yes.
Dr. Jackson,
Yes.
Mr. Brown, Mr. Gregorio,
Yes.
Dr. McDougall,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Rhodes,
Yes.
Dr. Silberman, Commissioner Valentine,
Yes.
Dr. Verbeest.
Yes.
All right, fantastic. Thank you, everyone. Next on the agenda are are there any items that we want to see added to the agenda for our August meeting?
Mr. Chair, I do have one request, and that comes from our Triple P program, who would like to present to this great board. Triple P stands for Positive Parenting Program. Durham is the regional hub for, I want to say, a 10-county region, and they are looking forward to providing this great board with a lot of updates as to the great work that they're doing. And we welcome any additional agenda items that you may have.
Sounds great to me. Any other additional agenda items that any of our board members want to request? All right, Dr. Jenkins, we'll leave it up to you and your team to add any other reports. I do believe that we discussed previously every other meeting being in person and every other meeting being virtual. I know it's a bit of a takes some effort, Dr. Jenkins, to host us, but I would like to propose that we meet in person in August.
Consider it done, Chair Ray. We look forward to receiving you all in person, and we will have everything ready. Lily is up for the challenge.
Fantastic. Thank you very much. All right, any informal discussion amongst the group? All right, hearing none, I will make a motion to adjourn into closed session pursuant to NCGS 143-381-11A3 to discuss the health director's FY25, FY26 performance evaluation. Do I have a second?
Second.
All right, fantastic. Ms. Cortez, if you could move us into closed session, please.
Dr. Ray,
Yes.
Dr. Jackson,
Yes.
Mr. Brown, Mr. Gregorio,
Yes.
Dr. McDougall,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Rhodes,
Yes.
Dr. Silberman, Commissioner Valentine,
Yes.
Dr. Verbiest.
Yes.
All right, fantastic. We will go ahead and Ms. Cortez, if you can do the Zoom magic to move us into closed session, we'll proceed then.
Ms. Cortez, I think I might need to go into closed session with them as the attorney.
We're gonna get you there right now.
Great. Okay, great. Thank you.
All right.
It's magic.
It is magic. We got everyone back. All right, fantastic. So thank you all for sticking with us this evening. Thank you, Dr. Jenkins and Lily. Thank you for all your hard work today on your first meeting. Great job.
Thank you.
I will unless we have more discussion, I will entertain a motion to adjourn.
So moved.
Second.
It has been moved and seconded. We are ready for the vote.
Dr. Ray,
Yes.
Dr. Jackson,
Yes.
Mr. Brown, Mr. Gregorio,
Yes.
Dr. McDougall,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Rhodes,
Yes.
Dr. Silberman, Commissioner Valentine,
Yes.
Dr. Verbeest.
Yes.
All right, the motion passes. Thanks, everyone. Have a great evening. Stay cool and go Hurricanes.
Bye.
Okay. Bye, everybody.
Everybody.
I'll take
Great
care.
job, Dr. Ray. Good meeting.